Thank you so much for joining me for FMC Live. The case that we've selected today for you is a lower left 6 that had deep distal caries. You're doing absolutely amazing. And prior to this visit today, the patient has had a restorability assessment due to the deep distal caries, whereby we did a pre-endo build-up. The tooth did require DME, and we've done the DME with a composite resin restoration, and the pulp chamber was subsequently dressed with a calcium hydroxide dressing and a temporary filling over the top. The challenges of this case, looking at it to begin with, is that the roots themselves are very long and thin. There are calcifications present or suggested on the radiograph, and there may be curvatures that we find. I hope you find this case interesting, and let's see how it goes. And most probably not a case that I would have liked to have selected, but we get better by doing these more and more difficult cases, and actually on reflection I'm happy with the end result. So let's talk through what we did today. Initially, when we opened up the tooth, there was no issues with rubber dam isolation, and we used a single tooth isolation technique as I'd already done the pre-endo build up. 2, we opened the tooth up, and actually the nice element was that we were able to locate the canals pretty easily. The benefit and what made that stage really easy was we did not destroy the anatomy of the floor of the pulp chamber. If we don't destroy the floor of the pulp chamber, it can guide us to the orifices. A good paper to read is Krasner and Rankow, 2004. That will give you further information on the rules of orifice location and help you be more predictable in locating canals. However, when it came to working length determination, as you can see, those canals were really calcified, especially the MB, and we weren't able to achieve patency straight away. It took a little bit of time. For me, I initially scout the canals to see how far the canals are open or patent without too much resistance, and then we do an initial coronal flare prior to determining working length. The orifice opener we chose in this case was HiFlex EDM's 1811 orifice opener, which is a part of the OGSF sequence. It's a nice flexible file, and the idea with the orifice opener is to only use it in the coronal threads. What that does is improves your tactile sense and gets rid of the initial curvatures and calcifications or constrictions, which allows our hand files to work better apically. Once we've done the coronal flare, actually in a few of the canals, with the use of a glide path file just short of what we believed the estimated working lengths to be, we were able to get patency in all of the canals. The distolingual took a little bit of time, and actually the MB was challenging right from the outset. We were struggling to get a size 8
the GI
down, but eventually we managed
with the
to reach there.
scale.
So then we need to consider our shaping process. Once we determined our working length, we needed to decide how were we going to prepare these canals. I decided to use the HiFlex EDM OGSF sequence, but actually it should be the anatomy that guides the preparation and not a manufacturer sequence. If you had a look or reviewed the case that I did, we did the orifice opener, the glider. The glider is actually really good at producing a glide path, which is a smooth, uninterrupted path from the canal orifice to the apical constriction. The glider reduces the stress on all the subsequent files to follow. So for me, I tend to use a glide path file in most cases, and the 1503 is a glide path file that I really like because of how flexible it is. It hardly has any restoring forces, and it has great cyclic fatigue resistance. That enabled me to get down to working length in a pretty predictable way. Furthermore, after the glider, we use the shaper, and the shaper is an 18 4.5% taper. It actually did require a few passes to get down, but I also, if you look at the preoperative X-ray and analyze the case, the canals were quite constricted, and also the canals were very narrow. So it was going to take some time to get there. Having got the shaper down there, If you're following the OGSF sequence, you would have finished on a 30.04, but as I mentioned before, anatomy should guide the preparation. Because the roots were so thin and narrow, I didn't want to over prepare the canals. And as such, HighFlex EDM also has, as well as the OGSF sequence, other files. So the preparation file is a 20.05 finish, and I decided that'd be appropriate in this case. Having used the shaper, we used the preparation file and then thoroughly cleaned and disinfected the canal systems, and I was happy with our shaping process. When it came down to the obturation, after our final irrigation protocol, my irrigation protocol is fairly simple. I use sodium hypochlorite throughout the whole process, penultimate rinse with EDTA for 1 minute or 1 to 2 minutes each canal, and then the EDTA gets activated with a sonic activation device such as the endo activator, and then hypo as a final rinse with some activation. Canals were dried, there was no pus or bleeding, so I was happy to obturate the canals. Now, obturation, the initial challenges, wow, how annoying, how frustrating. I could not get the GP cones down to length. And when I took my working length radiograph, they were a little bit short. But I was getting 0 readings when determining my working length. So instead of re-preparing the canals, I just tried a different brand of GP points, and those seem to fit a lot better. And as such, I used those to obturate the canals. The technique I used, single cone bioceramic, the canals were very thin, very narrow, and as such, I didn't want to introduce significant force within the root canal system. Also, they were quite round. As they were round, I was happy to use a single cone bioceramic technique. As you saw in the videos, we injected a bioceramic sealer within the canal without letting the tip bind, and then subsequently place the GP cones slowly to working length. Once we got past the initial differences, I'm actually happy with the end outcome. So challenges, yes, but endo is also about problem solving and thinking on your feet. And sometimes cases don't go as smoothly as you'd like. This was one that did present a few challenges.